Good afternoon, and I think it's time to start the session. So we have a very exciting session today. It's a really particular session. I will try to explain you the goal of this 2 hours. So the session focus on transradial approach. We start at 2 o'clock, and we have 2 hours and 30 minutes. And during this time, it will be particular. As you can see, the room is special. That is to say, we are, I think, more than around 480 people, and you have 240 microphones. So if you have this high number of microphones, it is to use them. And so this session will be really interactive. There will be absolutely no formal lecture. This is a goal, except one. Yves Louvain will show you some slides concerning the virtual reality. During this session, the goal is to communicate between you and the member of the panel. So we have Maury, Yves Louvain, and Gérard Barbeau here with me. And in Toulouse, in the CAT Lab, there will be two of the major operators when you talk about transradial angioplasty. The first one is Ferdinand Kimene, who is doing the first case. The second is Shigeru Saito from Japan. We will do the second case. They will be helped by my partner Bruno Farah in the CAT Lab. So we will start by the few slides just to precise the learning objectives of this session. We have three major learning objectives. The first one is to understand the anatomical differences between the femoral approach and the radial approach. So we could, during this session, talk about the usual radial anatomy, the usual anatomy of the brachial artery, subclavian, etc. The problem of the navigation, how to navigate with the guiding catheter from the radial to the ascending aorta. And if we have questions about that, we will talk about the different possibility of anatomical variations. And there is some variation. Some are quite frequent. The other one are less frequent. We will talk about that. The second is to see what if we need special tools, special material to do transradial approach. And I think it will be interesting because I think that Ferdinand Kimene will do the first case with the absolutely standard Judkins catheter. But we will discuss about and review the different material. And the third one, and this will be the major point of this session, will be to learn how to deal with the most frequent difficulties. And we will talk about the problem of radial artery puncture. It could be a problem for you, it could be not a problem, but we will try to see this more in detail. The problem of the spasm, radial artery spasm, how to prevent it, how to treat it. The problem how to deal with anatomical variation, and we'll see that sometimes there is no possibility and we will have to move for the other side or to the femoral approach. How to get the selective catheterization of the coronary artery ostia. And the last point will be how to improve the support with the guiding catheter, particularly in complex coronary lesions. As you know, we had, before starting this session, the two studies. The first, may I have the first lecture, please? The first slide, please. Okay, this is the from the EuroPCR online, so from the net, we asked several questions, and I thank all the cardiologists which came into the net and answered to this question. So the first question was, how do you estimate in percentage the risk of femoral complication during PCI? And you can see the Gauss curve, and the median is around 4%. Next. The second question was, during your procedure conducted by transradial approach, what is your major technical problem? Next. No, this is not... excuse me. The next one was, do you think that closer device can reduce the femoral complication, the bleeding complication? And nobody answered for positive, and everybody was thought that the use of closer device did not reduce the risk of bleeding access site complication. Next. Do you think that transradial approach can reduce bleeding access site? And we have exactly the same. 100% of the answers said yes. Next. The other question was, do you perform transradial approach during PCI via transradial approach? And in 70%, the answer was occasionally, and only in 1/3 of the answer, it was in routine practice. Next. If you perform PCI via transradial approach, is it routine practice? This is, I think there is a mistake on the this was, excuse me for there is a mistake on the question. The question was, what is when you perform PCI via transradial approach, your major problem? And you can see that the puncture represents 1/3 of the answer. The problem of the backup support with the guiding catheter, 1/3 of the problem, and the spas, coronary artery spas, 22%, and I was surprised by that, and the cannulation of coronary osteum, only 12%. Next. So this is the second list of questions asked by the Terumo company who sponsored this session. And this question was asked by all the guys who were around the world in the different cath labs since a couple of months. And this is the pre-request evaluation. So, as you can see, do you perform PCI by transradial approach? 94% say yes, and just only 6% say no. If you perform PCI by transradial approach, is it in routine practice or occasionally? It's close 50-50. In your experience of transradial approach, is radial artery puncture your main technical problem? In 72% of the cases, the answer was no. In your experience of transradial approach, is navigation from the radial artery to the aorta a technical problem? In 78%, the answer was no. Is selective catheterization of coronary ostia is the main technical problem? Is 50-50. That is to say, in 50% of the cases, the different operator will have the answer to this question, asked by the Terumo company, say yes, in 50% of the case we have the problem to catheterize selectively the coronary ostium. And is the spasm a major problem? In 83%, it was not a major problem. Next. I think it's the last question. There is no other. So, what we can do before starting, you have seen this different question and answer, but this maybe does not reflect this audience today. So maybe we can ask the same question, and we can have the result immediately. Can I have the first question? And you can vote. And this is very important to know exactly what is the level of the room in order to improve the quality of this session. Est-ce qu'on peut avoir les questions? So the first question is, how do you estimate the risk of femoral complication? 1 to 5. You can vote, and we can get immediately the answer. So it's between 2 and 4%, 37%, 4 to 6, 28%, and 1 to 2%, 20%. Next question. The closer device, can they reduce the risk of complication rate? You can vote. Yes, in 56%. This is interesting. Next. Can transradial can reduce bleeding access site complication? The vote is open. So the great large majority is think that we can reduce with this route the rate of bleeding complication. Next. So this is important. Are you performing transradial approach in your cath lab? So more than 2/3 of the auditorium is doing transradial. Next question. So is it in routine practice or occasionally? So routine practice represent only 1/3 of the people present in a room who are doing transradial approach. And this represents 70% at the beginning. Okay, next. So now we have just what are your principal difficulties when you are doing this kind of procedure? Vote. So this is interesting. The first major difficulty is the backup with the backup support with the guiding catheter, 32%, followed by the puncture, 25%, radiolatory spasm and cannulation, 70%, and the catheter navigation tool. So thank you for this question, and we will build now the session from this question. That is to say, you have two main problems. Problem of puncture, problem of the backup support with the guiding catheter. So before starting the procedure, we can talk about the puncture. Yves, you want to say something before the live transmission? We will talk also about during the transmission. Ferdinand will show you how to do the puncture. We will talk about all the difficulties we can have.
About the puncture, as I began the transradial approach in '94, I was using, as you, Jean, the Arrow kit. I think even Jean Ferdinand Kemenet is not using it now. So first I was using the bare needle. It was a 21 gauge needle. And I used it for 7 years until 2001. And in 2001, I was convinced by my colleague Thierry Lefebvre to use a Venous Schiss. And for me, it's now the best device to do the puncture. I know that we will exchange with Jean for that, because Jean is still using a bare needle. The advantage of the Venous Schiss is you can do, especially with very tapered Schiss, you can enter the artery, and you can try to avoid the transfixing puncture. When you push a needle, you first add a blood issue at the tip of the needle. If you push slightly more, you can see blood coming up in the Schiss. And if you still push a little bit more, you stop the blood issue at the tip of the needle. At that time, if you remove the needle, you are inside the artery, just inside, without transfixing puncture. So I think for me to do such a puncture is the ideal. Sometimes I do as others transfixing punctures. I'm not sure this is really a problem for a normal distal puncture, but I imagine, I have no proof of that, I imagine that if you have to do a higher puncture, for example after a failure, you may be not in front of bone. And if you are not in front of bone, the compression of the artery will be more difficult. And if you have done a transfixing puncture, maybe it will be a problem.
Well, my technique is about the same. I would like Jean to have the slides up. If you can go up with the slides, so I will explain my technique, and it's very simple.
So you have the slides now, but
I don't. Okay.
Is it okay?
Yeah. Okay. So this is. Can you go ahead and next slides? And I will show you something. First, that's how we drape the patient in our cath lab. We still prepare the femoral access just in case, because all our cases are ad hoc intervention. But what you see now is that basically we can begin the puncture. If you're not, let's say, used to do the radial puncture, you can begin immediately while the nurse is actually prepping all the tubing. So it gives you a little bit more time to have the access. Next slide. Next slides. This is exactly what I'm using. I'm using Insight. In fact, it's an 18 gauge, and the wire is a 0.25 straight and soft, not long, very short. Next slides. And I first use lidocaine, very, very little, just to anesthetize the skin. Next. And then I open the skin a little bit with a bistouri and a scalpel, just about 1 or 2 millimeter. It helps me it facilitates the movement of the needle. But sometimes if you use a smaller needle, you don't need. I personally transfix the artery, and one of the reasons is that the puncture will result in advancing a sheath about 2 millimeter in the anterior part of the radial, while the posterior puncture is very, very small. And anyway, when you will compress, both puncture site. And usually which one will bleed is, of course, the 2 millimeter and not the small by this. So I transfix, next. And as you see, it doesn't bleed more than that. So I just advance, next. The wire, diapo suivante. And I pull back a little bit the sheath, next. And I just stop the blood by advance. When it's bleeding, you advance the wire, and I would say that almost 100% you are in the center of the artery, and then you can advance your sheath. And so that basically summarizes how we do the puncture. And with passing, I was a lot experienced with the needle, and when I tried this new technique with the Insight, basically I converted it within a day. I said it's a lot better, a lot easier, doesn't bleed on your shoes, it's perfect, and the fellows just love it. So that's actually what I found the best technique for doing an approach.
Yeah.
You are still using the bare needle?
Yes, I'm still using the bare metal. That is to say, the technique described by Gérald, and I think that Yves, you are using the same technique now, and Maury also. Huh?
I'm using the venous sheath, the same as Gérald, not
so
the bare.
In this technique, you are transfixiant. This is the technique, and I'm using a standard needle. Open needle, and without avoiding to be transfixiant. But the rest is exactly the same. And it's true that to be transfixiant or not does not change the risk of bleeding complication.
I see one difference. When you use the sheath, if you have any problem to enter the wire for more than 10 centimeters, for example, you can push your sheath and do an angio. With a bare needle is more difficult, and maybe maybe dangerous.
Who is using in the room?
That's it, very important to see.
The transfixion technique, who is doing this? With very few. And the open needle, normal open needle, that's the majority.
And the second advantage of this plastic sheath is that you can do an angio. Second, you can inject the cocktail before inserting the sheath.
Sure.
But really, I was converted also very quickly, less than a week, to this new venous sheath catheter. But certainly, I still can do bare needle puncture.
One point I'd like to make.
Yes. What's important point is this. When you start the radial program, you have to take time to do the palpation of your pearls. And this is, I think, for me, the most important. And what I try to teach to all my fellows, take your time when to palpate the pearls. And take your time to try to see what is the course of the radial artery. Is it your artery straight or is there some tortuosity? And you can do the palpation. And particularly sometimes in a very old patient, you can have some tortuosity, and this could cause the problem of the puncture. And if you feel some tortuosity in the distality of the radial artery, what you can do is to do the puncture 1 to 2 centimeters more proximal to the distal tortuosity. This is the first point. The other point is that you have to place, after the palpation, you have to place your needle really coaxial to the axis, to the course of your radial artery, as this is shown on the screen. And the angle is around 40 degrees with the needle. Other comment? Yeah, Maureen.
When we decided to implement the radial approaching on URCAT lab, we had this approach. I was looking for an anesthesiologist, and he or her teach me before to start the program in the cath lab. So when we started, we know well the technique. And for 1 month, 1 month and a half, every day I was, and my colleague also, we were to the operating room from the cardiac surgeries, and to learn correctly the puncture of the radial artery, because the anesthesiology team is the people who knows better this technique, better than us. And for us, this was very, very comfortable to start.
There is another point, and very often when you begin your course in the transradial artery, this is one of the first mistake we are doing. I have done the same mistake in the past a lot of times, is to do the puncture too distally. The puncture too distally. Why? Because when you palpate, you feel your pulse, the best palpation is really distal. But in fact, you have to do the puncture proximal to the styloid process. And this is typical. You see this picture, patient, you can see the wrist. The first puncture was too distal, and we have the problem of spasm, etc. And in fact, the operator did the puncture 1 centimeter proximal to the first one, and there was no problem. Why? Because at that point, the radial artery is thinner and it's more complex. And there is a membrane. Anatomically, you have a membrane.
Jean, I would like to say also that if you stick distally, it will bleed a lot, because the artery is basically just under the skin, and it will take a lot more time to stop bleeding. So we noticed in our institution that it makes a difference in the time to put the small bandage.
Jean, just 1 or 2 more points about puncture. First, it was pointed by Gérald that you have to inject only a few lidocaine in order to avoid to change the anatomy of the wrist. In France, we have an alternative is to use a topical lidocaine. you have to put this topical cream on the skin 2 hours before the procedure. So you inject not at all subcutaneous lidocaine. And second point is very important, I think, is at the beginning is to work in silence. So you have to ask silence in the cath lab, because it's more difficult to puncture than the femoral, and to train you need silence. I think it's a very important point.
Any question concerning the puncture? Do not hesitate. Take your microphone, and I'm sure that in this room, some people disagree with what we have said. Do not hesitate. Is it clear?
Yeah, can I make a comment?
Take your microphone. If you can introduce your name and the city of your where you are working.
Claes from Germany. Do you always perform the Allen test before the puncture, and do you just do it manual or with the oxygen measurement?
Question on Allen test.
It's a good question. Who is okay. Well, the Allen test is a test that was developed a long time ago, of course, to evaluate the patency and the microvasculature of the end. But and it's an easy test to do, to perform it, but it takes collaboration for the patient. The patient has to collaborate. Sometimes old people doesn't want. So in my institution, we stopped doing the Allen test because we wanted not a subjective evaluation, but an objective evaluation. I'm from North America, so we sometimes need more proof. So what we developed is the plethysmography. And the plethysmography, as we see here, we put the plethysmography clamp on the thumb of the patient, and you see that there is a recording as well as you see the oximetry reading. Next. Why the thumb? The thumb is the last digit to receive the blood from the ulnar, and basically it would be the first one to have a problem if you end up having a circulation problem. The second thing we do is that we occlude the radial artery, and we check if we lose the plethysmography curve. And the plethysmography is a reflect of a pulsatile flow into the thumb. Next. So what we found I've done 1,000 patients like this on both sides. What we found is that you have a small amount of people having a type A curve. That is, when you start occluding the radial artery, you have absolutely no change in the oximeter as well as the plethysmography curve. And one of the reasons might be because the radial artery is occluded. So if it is occluded and you compress it, doesn't change anything. So you have a clue here. But sometimes you will see it in patients with IV nitro or young ladies usually. The most frequent is the type B. That is, when you occlude the radial artery with your compressing, you have a slight reduction in the plethysmography curve, but you still keep the reading of the oximeter. And that's the majority of patients. The type C is when you occlude the radial artery, you lose completely the plethysmography curve and the oximeter is negative. But if you wait, and in my paper we waited up to 2 minutes, and the reason is that the alarm is when of course it goes flat, the alarm starts, and then you can stop the alarm, and it's for 60 seconds, so you do two times up. And within 2 minutes, in the majority of patients, you see reappearance of the plethysmography, even if you keep on the occlusion or the compression of the radial artery and the oximeter. And it just shows that you can recruit kinds of collateral or pulsatile flow into the thumb. And finally, the type D is the patient, well, no matter how long you wait, you still have a plethysmography curve that is flat and a negative reading on the oximeter. So basically in Quebec, we do A, B, and C, and D, we try to avoid doing them. And that's why there is a question mark. I know that in some other countries, people don't even care about that. But I would say that from an American point of view or a North American point of view, we still prefer to have proof. The nurses does that, and it takes 1 or 2 beats to have that. You know, you occlude the radial artery, you see the plethysmography curve, that's it. I mean, you don't have to wait 2 minutes. If you see it, it's there. If you don't see it, you have to wait up to 2 minutes to match what we found.
John?
So what did we find in numbers?
Excuse me, the cath lab is ready now in Toulouse.
Yeah.
So we will discuss about the problem of Allen test, plethysmography during the transmission. Okay.